All right, pulmonary infections, pathophysiology. Infections are caused by bacteria, viruses, fungi, or protozoa. Infectious diseases cause swelling of the respiratory tissues. They have an increase in mucus production, and they also can produce some pus. Yum. With that, they do have increased resistance in the airflow, and they will, decrease that size. They'll cause some edema and stuff like that of the airway, and so it brings back into effect Poiseuille's law of increased resistance when airway size decreases. And the alveoli can become non-functional if filled with pus, of course. That could be pus or any sort of fluid that causes them to not allow gas exchange. Those at the greater risk of pneumonia are the older generation, of course, people with other chronic illnesses, people who smoke, because they're already letting all those toxins into the body. Anyone who's not ventilating efficiently, someone who's sitting in a hospital bed, just kind of hanging out there. A lot of times that instruction, all right, breathe deeply, get those nice deep breaths. Those with excessive secretions and those who are immunocompromised, all of those are at a higher risk. And they are recommended that they get a pneumonia shot, actually, on an annual basis, usually, to get that vaccine. It's something we want to watch for also as, paramedics and stuff, that we're, staying vigilant to cleaning our trucks and not infecting other patients. The last patient we had pneumonia. Well, now we need to give her a little wipe down and try to clean everything up so the next patient is protected, because we don't want to be one of those carriers. Okay. All right, our assessment for pulmonary infections is going to be patient usually reports several hours to days of weakness. They might have productive cough and fever, and then chest pain that is worsened by cough. The symptoms might have started abruptly or gradually. During the physical examination, we need to look to be vigilant. If they look very sick, they may or may not be coughing. If they have crackles on lung sounds, they might have some increased sputum production or some tactile fremitus, and they might have bronchial or bronchovesicular breath sounds over the areas of consolidation. Pneumonia most often occurs in the lung bases. Let's go with that. And usually it's only on one side as well. So, the bacteria and stuff works its way down in the lungs until it gets all the way down to those bases, and then that's when it can really cause the issues and get that infection going. Usually our patients are dehydrated, for whatever reason. They don't feel good, they don't want to drink, don't want to stay hydrated. And supportive care includes oxygenation, secretion management, and then transport to the closest or most appropriate facility. Upper airway infections require aggressive airway management. That's our asthma, COPD, stuff like that, given those bronchodilators. Whereas the lower airway infections, they need more supportive care. They need antibiotics, stuff like that, that they're not usually affected quite so much by the bronchodilators. They're not beneficial with the pneumonia and those lower airway infections. Atelectasis. With atelectasis, it's a collapse of those alveoli. They may fill with pus or blood or fluid, and it could be caused by smoke or some sort of toxin that is damaging those. It's common for some alveoli to collapse just in normal healthy people. That's why you sigh, you cough, sneeze, changing position, all that stuff helps open up those alveoli. When they do not reopen, then you can actually have entire lung segments or lobes that will eventually collapse. And with atelectasis, more atelectasis you have, the increased higher chance of getting pneumonia you have. Whenever there is atelectasis going on, those are perfect spots for that bacteria to just kind of hang out and result in a pneumonia. And so you need to check the patient if they got a fever, they're having shortness of breath. Well, have you had a recent chest or abdominal surgery or some sort of other surgery? You've been laying around a lot for some reason, and those can all be signs that might be atelectasis that caused that pneumonia to go on. With the post-surgical patients, they encourage them to get out of bed, cough, breathe deeply, use that incentive spirometer to help keep everything going. Lung cancer is one of the most common forms of cancer, unfortunately. It's typically most often caused by cigarette smoking or exposure to secondhand smoke. It's a big contributing factor to that. Could be some other occupational lung hazards as well. Hemoptysis is often the first sign, coughing up that blood, and frequently accompanied by COPD and impaired lung function for sure. And even if the cancer might not have started in the lungs, it's often metastasized in the lungs and allowed to grow there, might have moved from someplace else into the lungs, unfortunately, just because of the high amount of blood and stuff that goes through there. It's a very prime spot for metastasization. Other cancers may invade the lymph nodes in the neck. Radiation chemotherapy might cause pulmonary complications, and you could have tumors or treatments that may cause some pleural effusions with that, so just keep all that in consideration. Unfortunately, for pleural effusions and coughing up blood and hemoptysis, there's not much we can really do for that, and they're kind of sometimes called end-of-life issues. With that, and those patients on cancers, a lot of times cancer patients are given high doses of morphine, oxycodone, whatever, some sort of pain medicine, because it is a very painful disease process. And so we need to keep in consideration, if we're going to give Narcan or naloxone to improve respiratory drive, because maybe they've overdosed on that, we do not want to fully reverse the effects of that opiate. We want to only reverse the effects enough so that we get respiratory drive back. That's it. If you reverse the full effects of pain medicine on someone, that's battling cancer, that's almost inhumane to do that. There's a lot of ethical issues with that, so just keep that in mind. Very small doses of naloxone just to improve that respiratory drive, get them breathing again. You don't need them talking to you. You just need them breathing. That's all. With toxic inhalations, could be damage depending on the damage will depend on whether the toxin is water soluble or gaseous. I would say probably the most common one you'll run across is chlorine. A lot of people have their own pools at home, and they have chlorine that they're dealing with, and it can kind of burn the airways just a little bit. Usually not so bad that they need to call 911, but it does happen some. Ammonia is very highly water soluble and can cause some irritation for sure. And then phosgene can cause some pulmonary edema. Kind of a delayed onset on that. So highly water-soluble gases, like the ammonia, they'll react with that nice moist mucous membrane and cause that upper airway swelling and irritation. And then your less water-soluble gases get deeper in the lower airways and cause more damage over time. That's why that phosgene has that delayed onset pulmonary edema, because it is not very water-soluble, so it really gets down in the bases of the lungs and can really cause some nasty stuff. And nitrogen dioxide is going to be the same as that phosgene. It's not very water soluble. Moderately water soluble gases could just cause some irritation, or it might cause some pulmonary edema. You might have a little bit of each. That's why you need to get poison control on your side, contact them, figure out what it is and what kind of treatment you need to do for them. Mixing, of course, drain cleaner and chlorine bleach is never a good thing. It can cause an irritant and sometimes you can just get those people into fresh air for a while and they'll get better, but then other times then they actually do need some more aggressive airway treatment. Of course, immediately remove the exposed patient from the contact, provide them with 100% O2 or assist their ventilations. If the exposure is to slightly water-soluble gases, then they might have shortness of breath later, hours later, and it could come on quite rapidly. Pulmonary edema. So we got fluid buildup in the lungs when blood plasma fluid enters lung parenchyma, or parenchyma. Not sure how you pronounce that one. So there's a couple different root causes for it and classifications for it. It's high pressure, which is going to be caused more cardiogenic, and then high permeability, which is non-cardiogenic. That's more the lung issues. So with the high pressure side, that's often called heart failure that's causing this pulmonary edema. It could be right or left side. Chronic hypertension or cardiac disease, any of those can be contributing factors to this high pressure pulmonary edema. The more the permeability occurs more in acute hypoxemia, and it's more damage to the pulmonary capillaries by toxins or drugs in the bloodstream. Excuse me. So by the time you hear crackles in the lung fields, the fluid has already leaked out of the capillaries. You've got increased diffusion space between capillaries and alveoli, probably some swollen alveolar walls, and then they begin to seep into the alveoli as the fluid has, that is. And so those are all kind of, I guess you could say, later signs. I mean, there's not a whole lot that's real early on that you can see with that other. You just kind of have to wait to hear those crackles. You can listen to the lower lobes through the back. That's kind of if you can access their back like we talked about earlier, that's a real good spot to listen to the lower lobes. Crackles are heard higher in the lungs as the conditions worsen. I mean, like gravity, we know it moves up, and then in severe cases, watery sputum, often with pink tinge, will be coughed up. That's when we get that kind of hallmark pink frothy sputum that we talk about, that it's doing. It's actually red blood cells that they're coughing up that have crossed that capillary membrane and gone into the alveoli and then worked their way up. Acute respiratory distress syndrome, seldom seen in the field to a point. A lot of transfers out of like pediatric clinicals and stuff. We do a lot of those with, they've come in with shortness of breath and been diagnosed with ARDS, and now they're being transferred to, maybe a pediatric hospital or something like that. They're caused by diffuse damage to alveoli from the shock, aspiration of gastric contents, pulmonary edema, or a hypoxic event. Syndrome is worse when there's direct damage to the lungs, of course, maybe from barotrauma or something like that. And the alveoli actually become relatively stiff, and they become difficult to ventilate because they've lost some of that mucus that's down in there, and it's causing more issues. So with these patients, you're going to document the oxygen saturation, all those wonderful vital signs, and if there's any changes, and monitor the ventilation pressures if necessary, and try to make sure you're not having to overventilate them and using too much pressure to ventilate them if they're to that point of needing assistance with their ventilation. Other than that, there's not much else we can do for treatment on those. Pneumothorax, it's when air collects between the visceral and parietal pleura. Weak spots or blebs can predispose a person to those areas, or to the potential for a pneumothorax. And then once those are in place, it might be something as simple as cough or something that will break those weak spots and cause that pneumothorax. And it might be just spontaneous pneumo, where we're typically not going to be treating it unless it's a tension pneumothorax. So with that, patients may have sharp pain after coughing and then increased dyspnea in subsequent minutes or hours as that pneumothorax gets worse and there's more air building up in there. And it might not all be from one small hole in a lung. It could be from several weak spots that have all ruptured or something like that. Most patients will not require acute intervention. They should receive oxygen and close monitoring of their respiratory status. The body's pretty good at healing itself, and so sometimes that does it. What we need to be watching for is if it becomes a tension pneumothorax, then we need to be looking at decompressing the chest. That's when we get that tracheal deviation. JVD could happen. Loss of breath sounds on one side, and we'll kind of get more into that in the trauma section. Pleural effusion, it's kind of a blister-like sac of fluid formed when the fluid collects between the visceral and parietal. So it's kind of the same idea as a pneumothorax, but it's different pathophysiology behind it. It's more of a blister-like sac. Instead of just air escaping into that into your chest cavity, this is more of the fluid that is leaking into there. And you can actually have several liters of fluid in there. It doesn't have to be, we think of blisters, I could think of, sunburn type blisters where it might have a milliliter or milliliter or maybe 2 milliliters of fluid. This could have several liters. And it's all causing pressure and causing that lung to collapse. So it can be hard to hear breath sounds. Patient's position will affect the ability to hear them, of course. They're going to want to sit up, Fowler position, sitting straight up pretty much is most likely to be most comfortable for them. And then we're going to give them just supportive care. And then once they get to the hospital, they'll probably do some sort of thoracentesis or chest tube, something like that, to help drain that effusion. PE, pulmonary embolism. So it is a blood clot in the lungs, pretty much. Could be from lots of different causes. Fat embolism from a broken bone, amniotic fluid embolism during pregnancy, air embolism from neck laceration or faulty IV. That's something we can prevent right there. That's something we have to watch for, is that faulty IV. If you don't bleed your lines, say you're hanging a bag of fluids and you don't bleed the line and get all the air out of the lines, that can cause an air embolism for sure. So something we need to be watchful for. Even something as simple as bleeding the lock and the flut and getting all the air out of the flush or any stuff like that, we need to be watching for that as well. It could be a large embolism, or a large embolism usually lodges in a major branch of the pulmonary artery, and it will cause venous blood, so it can't reach the alveoli, cause that gas exchange. So that's why it's going to cause the chest pain, and then also a decrease in SpO2 and cause cyanosis. Usually won't resolve with oxygen. So usually your breath sounds are good, have good peripheral aeration. Classic presentations: sudden shortness of breath, cyanosis, sharp pain in the chest, and cyanosis does not end even after you give them the oxygen therapy. Often begins in a large leg vein and then will break off, like we talked about, kind of in the, if you're on a long flight or something like that and sitting for a long time, could form a little clot there. If you're laying in a hospital bed, could form a clot. And then break off once you get to moving around and then migrate into the pulmonary circulation. Thrombophlebitis, it's a high risk. It's going to be inflammation there, and that could cause, they're going to be at an increased risk for that pulmonary embolism. Management for these patients, typically, a lot of times they're bedridden. They're going to be given anticoagulants at the hospital, some sort of blood thinner. They might be given some of those, like they might call them diabetic socks or whatever, but kind of some compression stockings that'll help reduce blood clot formation. If they're frequent enough and bad enough, they might even go and put a Greenfield filter in, and that'll help catch the clots. And they can put those in many different spots. They might put them, in the thigh, as that femoral artery goes through there, stuff like that, or femoral veins. They can put them in several spots to help catch those. And it's like a little mesh umbrella that they put inside the vein to help catch everything. And then a saddle embolus is going to be a very large embolus that will travel up into the heart, and it just gets stuck right there where the left and right pulmonary bifurcation is, and it just is so big that it gets stuck right there, and a lot of times it just kills somebody immediately, and nothing you can do can change it, because it's blocking all gas exchange right there, and so you can ventilate and ventilate and ventilate, but it's not going to help do anything for the patient. And I believe that's it. We've reached the end of the respiratory chapter, 174 slides. Hope it wasn't too grueling for you guys, and y'all have a good day.